Bom, perfeito, 20 horas e 30 minutos,
All right,
então.
so 8:30. So let's
Boa
get
noite a
started.
todos.
Good
Nós
morning,
estamos
everyone.
aqui
Good evening, everyone. I would like to
com o
thank the
colega
presence of all of our colleagues
Carvalho, do grande
for another
anesthesiólogo,
Brazilian Journal of Anesthesiology webinar. And tonight,
uma discussão de um
I'll
tema
have a discussion about a
um tema
very
bastante
relevant subject
relevante no
matter.
momento atual e que certamente é do interesse
It's of
da maior
interest
parte dos
for
anestesistas e
most
anesthesiólogos do
anesthesiologists,
mundo.
not just Brazil,
Queria
but the
lembrar a
world.
todos que esse webinar vai ser gravado, em
It's
breve
going to
será
be
divulgado nas nossas
uh,
redes sociais e na
be
nossa página
recorded,
do
will be
YouTube,
spread in our
tanto para
social
os
networks and
brasileiros
our
como na
YouTube
versão em
page,
inglês,
the
e pode
English
ficar
as well as the
disseminado
Portuguese
posteriormente
version
para aqueles colegas
afterwards.
que
So
não
it'll be
tiverem
spread
ainda
for our friends that didn't have the chance to
tido
watch this
esse webinar e a
live, the
discussão hoje,
presentation,
né? E
the
para
discussion
quem ainda
today.
não teve
And
acesso,
to
a
moderate
doutora
this
Mariana,
event, we'll have Dr.
Lima,
Mariana
que é doutora associada
Pontes
do
Lima
Centro
Neville, Associate
Anestesista
Professor of Brazilian Journal
Universitário
and Anesthesiologist for
Lima, em São
Sabará
Paulo,
Children's Hospital and São Paulo
corresponsável
Hospital, on
pela
top of
realização
being the
do
one
exame PET
co-responsible
e
for
também
Unifest
coordenadora do Núcleo de
and
Suspensão
coordinator
Diagnóstica, além
of
de
the
ter realizado
SAS
seus estudos
nucleus,
pela
on top of
Faculdade
having
de
had a
Medicina da
PhD
Universidade de
with
São
the
Paulo.
São
Então,
Paulo
por
University of
favor,
Medicine. So
André,
please,
tenha
Dr.
a palavra.
Mariani, you have the
Boa
floor.
noite, André.
Good
É um
evening, Andre.
prazer estar aqui
It's
hoje,
great
uma
to
honra.
be here. It's an
Agradeço o
honor.
convite
I am thankful for invitation,
e
for the invitation,
realmente
and
é
really,
muito,
it's
muito importante que
very
estejamos aqui hoje
important
falando
that
desse
we are
tema tão
here
palpitante, tão
to speak
pungente
about
e de
this
grandes
important
debates entre os nossos colegas
debates
anestesistas,
and
tá?
such
Tenho
important debates
certeza que vai
amongst our
ser
anesthesiologist
uma
friends.
apresentação
I'm sure it'll be a
exaustivo e
great
proveitosa
presentation. It'll
e
be
assim, um
very,
prazer de convidá-lo
very
para falar
wealthy
aqui hoje desse
conversation. And I
tema,
had the pleasure of being
Dr.
able to talk
Florentino
about this
Fernandes
theme.
Mendes.
Dr.
Ele é
Florentino
professor
Fernandes
associado da
Mendes, he is
Universidade
an
Federal de
associate
Anesthesia e
professor from the
Saúde de Porto
Federal
Alegre
University of Sciences in Porto
e
Alegre,
um dos
Health
autores
Sciences,
do
and one of
artigo
the
publicado
authors of the
recentemente
editorial
na
published
Brazilian Journal of
recently in Brazilian Journal
Anesthesiology
of
e vai
Anesthesiology.
falar para a gente sobre esse tema
He'll
hoje,
be
tá?
speaking
Sobre
to
o
us about this
ordinário de
subject about
e
LP1
os seus usos
analogs,
perioperatórios e suas
their
consequências.
perioperatory
Muito
uses and their
obrigada
consequences. Thank you
e
very
passo a palavra
much.
para
And go
você, por
ahead,
favor.
please.
Bom, muito obrigado pelo
Thank
convite,
you very much for
obrigado,
the invite, for this opportunity,
Mariana. Olá,
Mariana. And hi.
esse é um editorial que a gente escreveu
So this editorial, we wrote
com duas
this
cabeças, né? A
three
Lorena
heads together, Lorena
a
Ebiapima,
Maristela Bueno de
Parcal,
Campos
Carvalho,
de Curitiba e eu de
I'm
Porto
from
Alegre.
Curitiba, and I from
As
Porto
facilidades da
Alegre. It's,
tecnologia da
it's the
informação que nos
facilities that we have,
permitem
IT technology that allows
vou
us for us
partilhar
to do
aqui de
so.
tela.
I'm going to share my screen here.
Estão conseguindo ver?
Can you see this?
Agora sim, mas ainda
You can
não
see it
estamos em
now.
apresentação.
Still not in
Não
presentation
está
mode,
no
though.
modo
I'm going to
apresentação.
place it into presentation mode, sure.
Ok.
Okay, now it's
Então,
good.
esse de fato é um
So
assunto
this is a subject
importante que a
matter
gente
that
deve
is
prestar
quite
atenção.
important. We need to keep an eye on
Eu não
this.
tenho nenhum conflito
I
de
have no
interesse em
conflicts of
relação a isso,
interest relating to
mas
this
eu
subject
vou
matter.
utilizar
I
um
will be
contexto
using
que
as
tem
a
um viés
context to say, I'm going to use it as a context. Let's say that I have a bias that is, comes
e
from the
tive a
Committee of
honra de presidir
Perioperative
e
Medicine. I had the
reger
honor of being the
qualquer
president
tipo de
of during
cirurgia,
3
gente, imagine se
rounds.
nós
So any type
otimizar a
of
condição
surgery, we
clínica
need
do
to
paciente
optimize the clinical condition of
e
the
para
patient.
restaurar essa condição
And to be able to restore
fisiológica o mais
this
rápido possível.
pre-surgical
Eu
condition as quickly as
considero
possible. I
principalmente
consider
que a
I
anestesia
consider
que a
that
gente faz é uma lesão
anesthesia,
menor para que
what
o
we do is a
cirurgião
lesser
possa
harm
fazer
so
uma
that
lesão maior.
the surgeon can
Estabeleça
perform a
o
bigger
tratamento.
lesion. And see this
Fundamentalmente,
as
nós
an inflammatory
temos dois
response.
fenótipos de
Basically, we
paciente.
have two patient
Um paciente não
phenotypes.
inflamado,
A patient that is
propriamente, que
non-inflamed,
nós
as non-inflammatory patient, we
chamamos
call
de
this
2.
as a 1
E
or
um
as a
segundo
2.
fenótipo,
The
que
second
é até
phenotype, which
20% dos
is
nossos
10 or
pacientes, é o
20% of
paciente
our patients,
previamente
is a
inflamado.
previously inflamed patient.
Tudo que a gente faz de medicina de
Everything that we do
evidências,
regarding
protocolos, é
evidence-based
no
medicine and
sentido de
protocols is in the
minimizar
sense
essa
of
resposta
minimizing
inflamatória
this inflammatory
e
response
proteger esse paciente da
and to
lesão
protect this patient from the surgical
adversa.
harm, from anesthesia
Bom,
harm.
talvez
So
os agonistas de
maybe the
receptores
agonists, the
tenham esse
GLP-1
efeito
receptors have
de
this effect
minimizar
of
o efeito
minimizing the
inflamatório desses pacientes,
inflammatory phenotype
porque
for
a
these
cirurgia
patients
acresce a eles
because
uma
surgery
resposta
adds to
inflamatória
them an
além de ser
an
sempre feito
acute
em
inflammatory
populações
response.
crônicas, como
Patients that
diabetes,
have
por
chronic
exemplo,
inflammatories, such as
obesidade
diabetes, hypertension, obesity, and
Eu
so
vou
much.
começar com
Add all that together.
o
I'm gonna
dogma
start
geral.
with the original dogma
Começou com
that started
Mendes, um obstetra,
with
em
Mendelssohn, etc.
1946, quando ele
So,
publicou seu trabalho com
1947, when he
44.016
published his
partos
work with
vaginais ou cesarianos,
44,000
ah,
C-sect
que
or
obteve
non-C-sect
66
births
aspirações. Ele
and
fez o cálculo da
66 aspirations.
0,3%.
He had a
E duas
calculation
mortes dessas
0.15% and
66,
two of the deaths out of those 66.
teve
So
0,045%. As duas
0.045%.
pacientes que
So
morreram
the two patients that passed
no
away
trabalho de Mendelssohn
in
aspiraram
Mendelssohn's work,
98%.
a
Isso é relevante.
solid
Tá?
content. So
Lembra que anestesia aqui, eu fiz
anesthesia,
esse slide, mas
slide,
fundamentalmente era sob máscara, sem intubação e
the
utilizando
mask
a
without intubation, and having used
Para
this.
discutir os planos de
I'm
dieta
not
que
gonna
você
discuss
coloca o
the med
paciente,
plans.
tá
How
todos
you
os
put a
textos mais
patient on
antigos.
older
Às vezes o
texts,
pessoal mais novo
maybe the
ainda
younger
não tinha
folks,
lido sobre
they
isso.
haven't even read about these
Mas
texts.
o Mendelssohn fez uma
But
recomendação
Mendelssohn
que
made a recommendation that
fizesse jejum durante o parto. Não
that
fez
you should
distinção
not be
se
eating
sólidos ou
during birth. There's no
líquidos.
distinction of it's
E
liquids or
tem um
solids.
trabalho, uma sequência
There
de
is a work in the
trabalhos
sequence
extremamente
that is
interessante
extremely interesting.
com
Read
estilando o conteúdo gástrico ou vômito humano em coelhos. E
is
aí ele chegou à conclusão de
rabbits,
que
and they
a
come to the
média
conclusion that the
de 2
pH
graus
below
era o pH
2.5
crítico, que dava
is a
pneumonia em
critical
coelho.
pH.
Não estou falando aqui em eventos de
So
vômito, não seria propriamente um evento
this won't be
fisiológico,
essentially
mas a
a substitute event, but a
fisiopatologia
physiopathology
acontece
of
no
that
coelho
which
bem
happens
diferente
on the
daquilo que
rabbit is very
acontece no
different from
humano.
what happens on a human.
O próximo passo
The
em
next step,
1970, Robert publicou
1970, Robert
né,
published
trabalhos sobre instilação de
about
conteúdo
installation of
gástrico no
acid
ventricular
contact
esquerdo do
on
macaco
the
rhesus.
left
Na verdade, ele
bronchi
nunca
bronchite
publicou
of a
esses
rhesus
estudos, né?
macaque.
Nunca, a gente não
They
tem
never,
esses
never
dados de
published these
quantos
studies. We don't have this
macacos
data.
foram injetados,
How many monkeys
instilados
were
com
injected?
ácido. E ele chegou à conclusão que o volume de
We got a
0,4
conclusion of the
ml
volume 0.4 mLs
provocava a
provoked
pneumonite química
the
no macaco.
chemical ammonia
E isso
in the
equivaleria a
macaque,
25
and
ml
this
de
would be
pneumonia
worth 25 milliliters
gestante.
in the
Vejam que desses
pregnant
dois
woman.
trabalhos
So
usando
these
esse
two works,
tipo
using
de
this type of
modelo,
outcome,
se
can be
obteve
obtained
aquilo
that
que
which
se
we
chamou de
call
volume de pH
a
crítico,
critical pH volume,
especialmente a partir
25
de
ml
2,5.
pH below 2.5.
E
And
na década de 60
in
ele
the
publicou
60s, this
artigos
took us to the classic
após a
NPO
meia-noite.
after
Vários
midnight.
estudos do Robert
Several studies of
com
Duckworth
protocolos com antiácidos já
protocols with
preparados.
anti-acid since the pH was low.
Descobri que, inclusive, o Roth publicou
Discovered
um
that
livro,
actually Roth
sobre
published
aspiração
a
de
book
conteúdo
about
gástrico.
aspiration of
Gastremia,
gastric
volume baixo,
content. Actually, it has
acontece
a
com
volume, but I would
embriões
hope somebody
acidificados.
to not need to buy this.
O grande problema desses modelos em
Problem with
obstetrícia
these obstetrician models that
altamente
the
de risco, com uma
population knew the risk
anestesia de risco,
with the risk
inalatória, sem
anesthesia,
intubar, utilizando
inhalatory
LEPs,
without being intubated,
foi
was that
generalizado para todos os outros pacientes.
it was
Como que
generalized
esse
for
risco
all
foi
other
o mesmo?
patients. Like the risk was the same.
Vejam que
You
a
can see that
aspiração do conteúdo gástrico
expiration of the
depende
gastric
de vários
content
fatores.
depends on several
Eu tenho
factors.
que ter um conteúdo
I
gástrico
need to
elevado,
have the gastric,
tá?
increased
Eu tenho
gastric
que ter um
content.
aumento
I
da
need to have an
depressão, que toda vez que
increase
ela acontece,
gastric
há
depression every time it
um aumento
happens.
associado
There's
nesse
also an
ambíguo vaginal
associated
superior. Eu tenho que
increase with the
aumentar a
lower
tonição e
sphincter. So
performance
there needs
desses
to be a diminishment of the
inclusive
tonus of this
regurgitação
sphincter.
quando
There needs to
feito na
be
quantidade
regurgitation of the
razoável
amount of a
de
reasonable amount of
aspiração
content,
desse conteúdo.
aspiration
Esse
of this
conteúdo tem
content.
que vencer
This
os
content
mecanismos
needs
de
to
proteção das mulheres
beat
que são
the
importantes
airway
e que
mechanisms that
encadetam
are
a
noticeable and they
pneumonia.
need to
Eu vou
result in
excluir desse
pneumonia. I'm going to
processo,
exclude
vou fazer
myself from
depois,
discussion. We can
as
debate
aspirações que aconteceram
afterward, but
por
the aspirations that
ingestão
happen due
inadequada de
to an
inibidor
inadequate
neuromuscular. Se eu
inhalation of
olhar do ponto de
neuromuscular
vista
inhalers. So
mecânico,
we look at it
nós
from the
temos
mechanical
contrações
point of view. We
importantes no
have
esôfago. O
noticeable
esôfago está
contraction of
sempre
the
contendo,
esophagus.
né?
It's always empty.
O
So
estômago tem dois tipos de
stomach
contração, um
has
que
two
mistura
types
a
of
proteína
contractions, one that
com o químico
mixes the
e a
chemo,
segunda
and a
contração
second
usualmente
one
quando há conteúdo
usually
gástrico
where there is
no ânus,
gastric
é uma
content,
contração, então uma onda de
a
peristalse que leva para
contraction, a peristal
contrair o
wave
líquido
that
refrigerante
brings this
abrindo
content of
o
head,
esfíncter
opening
piróico e
the pyloric sphincter,
liberando o conteúdo
and
hematopoético.
releasing the content.
Usualmente, esvaziamento gástrico
Usually,
depende
the
do
gastric
conteúdo
leaks
líquido
depend
e do
on
conteúdo
liquid
energético
content and the energy content of
desse
this
conteúdo líquido.
liquid content.
De tal sorte que tem vários trabalhos
As such,
mostrando,
there are
nos
several
Braz, por exemplo,
papers
que
showing
após a
that
ingesta de 500
after the
ml
ingestion
de
of
líquido,
500
10
liquid
a 15
milliliters,
minutos
10 to 20
depois, o
minutes
estômago vazio.
afterwards, the stomach is empty.
Então, o primeiro detalhe que a
So,
gente tem
first
que
detail that we must
definir
define
é que tipo de dieta
is what
os nossos
type of
doentes vão receber,
diet
que
these
tipo de
people will be
conteúdo.
receiving, what kind of
Mais
content.
recentemente, vários
But
trabalhos
more recently,
mostraram
several
que,
projects
utilizando
showed that
ultrassom, o
utilizing
conteúdo
ultrasign,
gástrico, então,
the gastric
não é mais
content
10, mas é
was
4,
no
passou a
longer
ser
before it started
1,5
to be
ml por quilo.
1.5 milliliters per kilo.
Mesmo assim,
Even
50%
so,
dos pacientes
50%
diabéticos
of
têm
the
mais de
diabetic
1
patients
ml por quilo
may
no
have more than
estômago.
1 ml per kilo
terço
in their
de
stomach.
pacientes
One
submetidos a
third of the
cirurgias
patients going through
ginecológicas também.
gynecological
É muito
surgeries as well.
provável que a
It's very
gente tenha uma
likely
anestesia
that
e
we
anestesiado
have
pacientes com
anesthesia
conteúdo gástrico muito
patients
além
with a
de
very
1,5 ml.
way low,
Eu só
way
fico
beyond
imaginando
1
quando você
milliliter and a
produz
half.
2
Remember
litros
that
de
we
saliva
produce
por
2
dia.
liters of saliva per day.
O suco gástrico fica em torno
That the
de
gastric
1
juice is
litro
around
mais a
1
2
liter or
litros
more,
de produção
2
de suco
liters
gástrico por dia.
production of gastric juice per day.
Depende da fase
Depends
cefálica,
on
se a
the
gente está
on the
com
face
fome
or
de
on if we're
alimento
hungry, thinking
com
about food.
olfato, né, estimulado por
This is something
alimento,
that is
você
stimulated
pode ter
there.
até 400
I guess you
ml
can
de produção
actually
de
have
suco gástrico.
400
O
milliliters
GLP-1, nós vamos
gastric
ver,
juice, so a
aumenta essa
GLP-1
produção de suco
that
gástrico, mas
increases the
explica
position of the
qual é a
gastric juice. We're going to have to
fisiologia
discuss
disso,
the
que é
physiology of
exatamente o que
this.
acontece. Se eles aumentam o pH, se eles diminuem o pH, se eles
So
estimulam, porque o estímulo é via
the
vago,
stimulus
a
is
produção de gastrina, de ácido clorídrico, de
the
pepsina
chlorides,
e essas mudanças.
peptides, and these
Então há
changes.
uma questão
So there is a
metabólica
mechanical matter,
e há uma questão de produção de líquidos e de
the
ingesta
production of
de
liquids
conteúdo
and
energético
ingestion
que
and
precisam
energy
ser
content that
discutidos.
must be
Não é
discussed.
só uma questão de dieta nesse
Not a
contexto,
matter of diet
de
within this
volume de
context.
resíduo nesse
Yeah, and a
contexto.
residual volume in
Há
this
mais de 20
context.
anos,
More
Grêmio
than 20
Revisão da
years
Conduta
ago, there was a
mostrou
Cochrane
que
revision
a
showing
abreviação do
that
jejum com líquidos
abbreviation
claros,
of
comparado com o tradicional
not eating
NPO-4
with clear
até meia-noite,
liquids after
não aumenta o
midnight
risco de aspiração,
does not
reduz
increase the
risco de
aspiration risk
mortalidade e volume gástrico. Tem
and
um estudo
gastric volume.
também
There was
feito só com
also
pediatras,
studies
que eu
with
não
pediatric
coloquei aqui.
patients. They just
E
didn't
nós
put it
temos
there.
o guideline da Sociedade
We had the
Americana de
guidelines
Anestesiologia,
and the
com
American Society of
31 sujeitos
Anesthesiology with
doentes
31
randomizados,
clinics,
2 não
randomized
randomizados,
clinical
uma
trials, two
randomizado
non-randomized plus
controle,
one control
mostrando
study
que
case,
o jejum
showing
abreviado com
that
líquidos em
abbreviated
nenhum
fasting with
convencional
liquids and
não
conventional
ocorreu em
fasting did
nenhum
not
caso de
occur
aspiração.
in any
Ou
case of
seja,
aspiration.
o
So
padrão deveria ser
the
o
standard
jejum
would
abreviado,
be abbreviated fasting,
principalmente porque eu quero buscar o
especially
efeito
because I want to
incretino,
look
e esse
for the
efeito
N
que a gente
creatine effect, and
procura.
this N creatine
O que
effect
é
is
isso?
important.
Os meus
What
serviços
is it?
são bem
Well,
treinados, os digestivos muito treinados disso.
they're
Ao
very well
invés de
trained
uma
for
coleta
this.
de soro
Instead of
glicosado
being a
com 5
glycose
ml antes
serum,
da cirurgia, o que dá 50
glycosated
gramas de
serum, which
glicose,
gives you
a
5
gente
grams of
passa
glucose.
50 gramas por via oral.
Give
E
them
aí eu
these
tenho um
50 grams
estímulo de
orally,
liberação de
and I have
insulina
a
e um
stimulus head
melhor
release of
controle
insulin and the
glicêmico
best
perioperatório.
control, perioperative control
Bom, e aí vamos
for
ver o que são
glycemia.
as incretinas,
So,
porque
what are
elas
incretins?
são
Incretins are actually
substâncias derivadas do eritritol
substances
saturados.
derivated
No
from
pâncreas se
glucagon.
produz
The
glucagon.
pancreas used to
As
produce
células
glucagon.
L do intestino,
The L cells and the
utilizando também
intestines,
uma
the
molécula precursora,
digestive tract,
levam à
even
produção do
using
GLP-1
the
peptídeo
molecules, the
glucagon,
ALG1
glucagon.
peptide, similar to
Levam à
glucagon.
produção do GLP-2 também, que é uma outra discussão interessante.
The GLP-2
Um outro
production as
leva
well.
à
There's an
produção
interesting
insulina
function, which
inócua
is
dependente
there's
de
the
insulina
insulin,
no
depending on an
trânsito
insulin,
precoce. Qual é a
when there are
resultante, os
glycodes.
efeitos
So,
colaterais disso? Leva
what
ao
is the result
aumento
of
da
this?
liberação de
The
insulina
stimulus,
do
the release of
receptor
insulin,
creatina,
the
né?
creatine effect,
Diminuindo então a
the
glicose
reduction
sanguínea
of
e
the blood
inibindo o
glucose,
glucagon.
inhibiting the glucagon. There's no inhibition of glycogenolysis or the reduction of glycemia. But these incretins, these are quickly metabolized by DPP4. They last for about 2 minutes. It just so happens that he managed to do this in drugs that inhibit DPP4, making small changes to the glucagon molecule. You have drugs that we call GLP-1 that act on the GLP-1 receptor, and these are small changes in a few amino acids on the chain, the peptide with the immunoglobulin or associating albumin with an infinity. I think it's very easy actually to be able to make these pharmacological manipulations. It just so happens that increases the secretion of insulin dependent of glycocytes, stimulating the beta cells of the pancreas, increases the biosynthesis of the insulin in some patients, even diabetic patients, type 2 diabetics, they end up being cured because it increases the beta cells and inhibits the glucagon. The issue is that there is an effect diminishing the gastric emptying, and this effect is very much relating to vagal stimulation of these incretins. On the other hand, if I look at it from a perioperitory point of view, these operations lead you to a diminishment of glycemia without a significant increase of hypoglycemia occurring. And this is an event that we must look at very carefully, because the resistance to insulin and hypoglycemia is related to adverse effects. And there is the immune response of the person at the point where they need it the most. I counted more than 70 formulations that are associated in research relating to these medications. I'm going to have a lot of news very quickly. Fundamentally, there's a half-life, an average half-life. And a few medications, as I said, that when injected in the subcutaneous, they have a half-life of weeks. I can see it as well for slow liberation. There is a 5 weeks. So we have two situations: short shelf life and a single dose.
Utiliza eventualmente uma vez por semana. E existe a
There
própria
is a semaglutide. There are pills of 3, 7, 14 milligrams with a short half-life. But very recently, last year, there was a directive of the Brazilian Society of Diabetes alerting, and it was an alert according to the increased risk of aspiration. Works, of course, you digest it with the endoscopy. The Perioperative Medicine Committee, using the same data, emitted this alert. The American Society of Anesthesia also had we have a problem. We need to see the problem. So the problem is maybe we need to take care not to go into a primitive dogma. Obstetrician risks. Patients with MPO, there are important adverse effects. I'm not going to discuss this. We can debate this later. Well, the guidance of this study is level C. I don't know what realized because I remember the directives are not placed there, but if you use the opinion of a specialist, the main study is the Silveira study, which is a Brazilian who published 33 patients were in the semaglutide, and the other 470 patients here, almost 90% used to lose weight. So another indication, 12% of the sample of diabetic patients. If you look at the fasting, it was more than adequate. And anesthesia was a deep sedation, fundamentally using propofol. The goal at this prospective cohort identify the presence of gastric as a secondary objective bronchoaspiration. So you can see that the results, there's an increase of the gastric residue, close to 5 times the control of solid residue. And then the endoscopist is the one that classified residue, and the residue is considered to be 0.8 milliliters. We can discuss this. The presence of residue that, hold on, I'm going to try. Semaglutide, and it presents digestive symptoms that is extremely frequently use of the receptor agonists, LP1 agonists, 40, 50, 60%. There is nausea, vomit, eventually diarrhea. These symptoms eventually lead us to abandonment of the treatment in a small amount of patients. Sure, the patients, the gastric ones, they were complaining. The drop was 10 days for the patients that presented gastric residue. It was 11 days in those that didn't. It happened in this casuistic one case of aspiration. So we're going to try to take a look at what happened. Post-op and the bariatric surgery, they made a gastric bypass, and this patient aspirated a large volume, but it's a risk patient. So, going back to this alert with some care, now we're going to take a look at this alert with seriousness. So, on the other hand, looking at the preparatory medicine and these the agonists, the receptor LP1 receptor agonists, this is all the mortality causes. They diminishes the internment, the hospitalization time, the hospital, due to cardiac insufficiency and for larger cardiac events. Extremely relevant situations for us to be able to put the patient in the post-op. At a high mortality risk, always be to improve the safety for the anesthesia patient. We need to start discussing the need for studies to assess and make a risk-benefit analysis and increase the incidence of gravity to this respiration, if it's a liquid with solid, which conduct there. So relating to the benefits, likely benefits when it comes to keeping this medication. What is the risk that these patients stay on if we suspended the medication, leaving them unprotected, relating to the inflammatory response? And this editorial brings these answers that we try to look for. So we look at the diabetic patients. A big database that is extremely relevant with 114 million registers. What organization, health organization that is extremely important that would feed these databases. So looking at the endoscopy data from 2018 to 2020, the use of GLP-1 agonists and receptors increase the risk of pneumonia, respiration, in 20%. Associating with this risk is the propofol sedation, antidigestive enzyme. There's no increase in the risk of the low digestive enzyme, a low one, which is defined from this initial study. Something that I don't believe much in. So the authors of this work the sphincter and the lower sphincter for the endoscope are the most responsible for the eventual increase of aspiration pneumonia. And I put down a phrase which I put in caps here, with that the results of their study cannot be generalized as we did with the Mendel's studies. So above is the article name. I'm going to discuss a few things relating to diabetic patients. This study is extremely relevant for us. More than 23,000 diabetic patients, 14% of them using GLP-1 agonist receptors. So they go to the emergency room and they need surgery and they can't be suspended. The author's questions associated with a higher risk of pneumonia for aspiration, respiratory insufficiency, or intensive therapy, hospitalization. So it's suggested for complications of 1.03. So not that associated to the risk increase. So conclusion of the authors that I don't endorse, I'm going to discuss this too much. The directions to suspend the receptor GLP-1, those are extremely recent articles. These are articles that are not published in our magazines. Following up with the diabetic patients, what is the risk of post-op complications with the GLP-1 receptors? About 130 million diabetic patients in the US, 2015 to 2023, going to 16,000 surgeries on these patients. So that GLP-1 agonists, they use the GLP-1 agonists using a conventional treatment for diabetes. So there are several agonists included in this study. What is the outcome? Well, the outcome was to use for more than 6 months, or that will only have entropic use just this time, but they went back the GLP-1 agonist, even though they interrupted it during a period. The risk of inspiration, the post-op did not go up. Once again, continuing for the diabetic patient, prospective cohort with 48,000 patients above 65, and that is a population that is interesting to take a look at because it's a population usually sicker. They need a higher cohort. That's it, but a patient above 65 years of age is not modified. 60,000 exposed patients, there was no increase in pneumonia. So in the retrospective, only patients that went for generalized surgery, few patients in the cohort, they were submitted through inductive anesthesia. So matching 352 non-exposed or semaglutide users, there was no increase in pneumonia. See, this is the meta-analysis. It's very relevant as well. Cardiovascular events for diabetic patients, GLP-1 agonists, their use have reduced the cardiovascular events and the mortality for all the causes for diabetic patients. What is in fact a real risk? Respiration pneumonia, what is the benefit that we will have to take a look at for these patients? Well, then surgery and all these types of surgeries, the better glycemic control it is, these respiratory controls. The agonists, GLP-1 agonists, they reduce the hemoglobin, which is a marker as well for more mortality, the post-op. I'm talking about diabetes patients. A very interesting study, 417,000 patients that suffered with acute kidney failure. They wanted to be operated. They were included in the cohort. Those that eventually went back to dialysis after improvement, they were excluded. And so I have 7,500 using GLP-1 agonists and 158,000 non-users. That's kidney failure. They needed hemodialysis, and
follow-up de 5
there's
anos.
a 5-year follow-up. Actually, in the publication, 2.5 years. Agonists for GLP-1 receptor, they reduce mortality at all the causes, and they reduce cardiovascular events and adverse kidney events. Very relevant. Diabetic, I'm gonna take this other study that we must reflect upon, and I'm gonna try to read this study in a different manner. These are non-controlled patients with type 2 diabetes, conventional treatment, and patients that are diabetic type 1 with a conventional treatment, and agonists for GLP-1 receptors. So looking at this study relating to the control, it increases the speed, like speed of leukocytes. It increases, but it diminishes the leukocyte flow, it diminishes the adhesion. Molecules be selected, he can eat them. For those of you that look at this, and I would usually have to read the neutrophil, maybe the monocytes in this process, that there is an improvement in the inflammatory response. The initial one and the acute response depends a lot on the neutrophil. But moving on with this study, the GLP-1 lowers the production of reactive species, oxygen species. So this increase of this is relating to a larger amount of thromboembolic phenomena relating to the inflammatory response. Diminishing of the reactive species of mitochondria, less mitochondrial stress, less endoplasmatic stress, it diminishes the production of and maintains a better integrity for the membrane, and it lowers the production of metalloproteins. These enzymes are related to stellar matrix fusions. So these enzymes that are more inflammatory cytokines, they have your stimulation of diastrocytes and glial cells of the central nervous system. So they move on to having an inflammatory phenotype. You can see that the authors can synthesize all their finds in this image. The GLP-1 agonists, they diminish, there is an effect, diminishment of the inflammation effect, the diminishment of the adhesion of molecules, an increase in the speed of the, and here I'm already reading the leukocytes. It diminishes the adhesion of these the telomeres. The reactive species for oxygen. It improves the development of the mitochondrial performance and the consumption of oxygen, and actually diminishes the deposit of plaques on the intimate layer of the carotid, diminishing the phagocytosis for macrophages. So it's clear till now that GLP-1 agonists, not just an increase of gas content, there are actually several other organ economies. There are GLP-1 receptors that practically all use. I will not be speaking much of this because that's not the idea. We can debate this later. Systematically, it diminishes inflammation in the heart, lowers the blood pressure, increases the heart frequency as receptor agonist and the age method, so it improves the contractivity, like goes in the function of the endothelium. So we have the inflammatory obese person, obese patient, they have systematic retention of water and sodium, adipose tissue remodeling of the left ventricle, see the receptor agonists, reactive species for oxygen, inflammation, diastolic pressure, activation of the testosterone, and plasmatic expansion. It's not just the effect of the content of the gastric product. We need to pay attention to this whole content. See how interesting it is, the provocation for the research. If there is an agonist of a receptor, a GLP-1 agonist, will take before a surgery, it was efficient in the reduction of the glycose and the need for insulin and cardiac heart surgery in patients going for non-cardiac surgery. So a great plan for the whole thing, but here there is no risk of retention. The patient is fasting, so I'm going to look for the incretin effect, and I will have the best metabolic control and the least insulin resistance. So moving on, we look at research matters, and it's clear that we will have to look more and more attentively responding to this. For instance, it lowers the inflammation, increases memory. It's being used with patients with Parkinson's or expressive improvements patients with Alzheimer's. There are several discussions that we can do according to GLP-1. There is vagus nerve because it's a big anti-inflammatory. And the hypothalamus, adrenal, can be adrenal, lowering the release or the sympathetic activation. That is the big inflammatory axis. An aspect I wanted to speak about is tachyphylaxia. I said that would happen with a continuous use of the GLP-1, and maybe this initial endoscopy impact this will happen in a different manner if we choose the patients 4, 5, 6 months of the use of this European study. It's a gas. It went back to values closer to basal values, but regarding experiencing the agonist, the GLP-1 of short action agonists. Eventually, this can continue with the effect for the gastric emptying, but I put here that it doesn't seem to have increased the risk of nausea and vomiting post-op, which is another effect that we will have to take a look at. And these studies, there was not a primary outcome. So it seems like it doesn't increase chance of nausea and vomit. Agonists, GLP-1, for the use of chronic pain, reduction of the prostate cancer above 6 years, very significant with the systematic revisions and meta-analysis showing this effect. It's being used for hepatic steatosis, several studies in animals and a few studies in humans evidencing the positive effect within this concept. Polycystic ovaries. Seems like the usage that started with diabetes, extended to the obese, and it was used to diminish weight and spreading as studies are being done in several areas. So, including the evidence here is insufficient. Actually, for the endoscopic surgeries, which is where the problem became evident, and we're going to need several well-designed studies to establish for a fact what is the risk-benefit relation and what is the implication of the patient that has this inflammatory response. Suspension of these medications at the point where we can do a surgery. You're gonna have a new inflammatory response. For these patients with luck, what can eventually say is that the risk of aspiration, if it exists, is low. Diabetic patients and other populations we will need to study and to understand physiopathology on the aspiration and understanding that the use of GLP-1 agonists will go up. And, I don't know what the patents are for all of them, but there is one that had the 2005 patent. So next year, the 20 years are old. Maybe the main alert that we tried to work with the editorial is that we do not commit the same mistake as what happened relating to generalization to the risk of the Mendelsohn syndrome on obstetrician surgery. We need to be very careful when generalizing these finds of the high digestive endoscopy relating to the other patients. Thank you very much, everyone, and that's what I had to say. Thank you, Professor Florentino. Great presentation. Very good to learn a little bit more about systematic benefits of this type of medicine that is great, and we'll be running into further and further. Very clear in the presentation. A lot of care. We need to embrace all the information in a very critical manner, in a very careful manner. So we can't be that liberal to increase the risk of such a serious outcome, which is pneumonia, and nor is so conservative to demand a time of suspension that is not vital and letting go of all the benefits of this medication. It really is a difficult balance. On a very clear middle term. We have Lorena here.
A Lorena,
Lorena is she
anestesista do Hospital Geral de
anesthesiologist
Vargas
for the Getúlio Vargas
e também
Hospital in
diretora
Piauí.
secretária-geral da SBA. Obrigada pela sua participação,
Thank you
Lorena.
for your participation, Lorena.
Eu queria abrir para o
I
André
wanted
e para a
to open
Lorena
for
talvez
Andre
fazerem
and Lorena. I know if
perguntas
they have any comments.
e queria agradecer a participação de todos também.
I
Pedir
wanted
que vocês
to thank you for the
enviem suas
participation, everyone. I would
perguntas
like you to
para
send your
o
questions for the
Q&A. A gente tem
Q&A.
aqui uma pergunta.
I have
Mas
one
antes disso, eu
here
queria ouvir
already.
os
Before
comentários
that,
do
I
André
wanted
e
to
da
hear
Lorena.
Andre and Lorena's comments.
Lorena, contigo.
Lorena, go ahead.
Beleza. Boa noite.
Good evening. I am thankful for the invitation to be able to debate the session,
Professor Florentino, pelo
and Professor Florentino for the invitation to be able to be part of this editorial.
Realmente
Really
ponto de vista
was a
fenomenal que a gente
great point
estava
of view
só
of what
vendo
we
do que
were
estava na nossa frente,
hearing, what
vai
was
ter
seen, what was in front of
regurgitação,
us.
vai
It's going
ter
to be a
via aspirativa.
pneumonia, respiratory
E
pneumonia, and
hoje,
he basically made us
visualizando com
visualize it
super
with
estudo, né,
this wide
de
study
vários
of
artigos,
several
vendo os pontos de vista dentro
articles,
do
several point of views
GLP-1,
related to GLP-1.
já que, na verdade, a gente tem que pesar muito
Really
bem,
understand that we need to really
primeiro,
weigh
qual a
things.
aplicação que a gente está tendo desses fármacos, qual é o tempo de uso,
What
qual
is
é
the
a dose, que
usage
tipo
time?
de
What is the
fármaco,
dosage?
isso é
What is the
muito
type
o
of
tipo de uso que tem que
medicine
fazer,
and what
do
is
que
being
só,
used?
assim, não, a cirurgia tem que ser postergada,
Surgery
isso é
needs to
muito
be delayed, and it's
simplista, né?
very simplistic.
Então, abriu aí um debate
So it
muito
opened up
rico,
a
a
very
palestra
good
realmente foi
debate.
excelente, traduziu
And it's
realmente
a
as
very
nossas
good
expectativas, né,
presentation. We
com o
translated our
editorial que ele encabeçou,
expectation with the editorial it
e só
led,
agradecer
and
mesmo pela oportunidade e tenho
just thank you
certeza
for the
que vai gerar
opportunity.
muita discussão aí pela
Sure, it will
frente.
generate a lot of discussion of more.
Obrigada,
Perfeito,
Lorena.
Agradecer
Lorena.
também a você, Mariana,
Thank you, Mariana,
nova editora
also
associada,
our
é um
new
prazer ter
associate
você
editor.
no nosso grupo. De verdade,
It's
muito
good to
obrigada.
have you in our group. It's great
Prazer
to
é todo
be
meu.
here. Thanks. The pleasure's all mine.
Obrigado, Lorena.
Thanks, Lorena.
Particularmente, parabéns pela brilhante
Congrats for your
apresentação,
great
né? Realmente um
presentation.
tema super relevante.
It's a very
Então, acho
relevant
que
subject
resumiu
presentation. If we could
todos os
summarize
componentes
all the
principais que a gente
components.
precisa ter nessa discussão, né? E a minha pergunta,
And my
antes da
question,
gente passar as perguntas da
we'll
audiência,
move
né?
on to the
A primeira
audience
que eu
questions.
faço ao professor Mendes,
Yes,
deixa
I
eu só
asked
lembrar, né?
Professor
A
Mendes.
outra
I wanted to
SBA,
remember the
uma força-tarefa
positioning,
da
which is
SBA, que foi
the SBA
organizada
task force that was organized some time ago
antes de alguns desses trabalhos
before a few
serem
of these
publicados,
works have
que
been
foi
published.
uma força-tarefa que se
The
posicionou
task
junto à
force that
Universidade de
positioned itself in the
Janeiro
name of
muito
the SBA to
conservadora em
a pretty
termos
conservative
de
manner in
tempo de
terms
suspensão.
of the
À luz
suspension
do
time.
conhecimento atual, dessa revisão que o senhor fez mais
See the
recente,
current
até colocou algumas
evidence, but
controvérsias, né,
actually
de
it was even more
observação
controversial,
dos tempos
considering on
tão
top of the
longos,
time
né,
is too long time
recomendados por
frame
aquela publicação que nós temos recentemente
publication that we
dessa
have
força-tarefa.
recently
Qual seria
of this
a sua
task.
análise daquela recomendação que foi feita em relação ao que a gente tem de evidências mais recentes?
And more recent
Muito
evidence.
obrigado pela pergunta,
Thank you very
Florentino.
much for the
Para a
question. It's a
gente
very good question
entender
for
o
us to
processo todo.
understand the
Eu não posso
process,
examinar o passado com uma lupa
examine
de
the
hoje,
past through the
porque hoje as
today's
coisas já
lens.
mudaram em relação àquela recomendação e ela vai ter que ser
To change
refeita.
the,
E talvez a gente vai ter que ter mais velocidade.
need
A
to have more
quantidade,
speed.
eu tenho aqui no
The
computador
amount that we
300,
have here in the
400
computer, you have
estudos
300,
iguais a esse, eu
400
tive que escolher
studies.
alguns para colocar. Bom,
So
passado o impacto inicial, porque eu fui lá para a endoscopia e
the
realmente a pessoa às
oscopy,
vezes se assusta. Tá?
you become scared.
Passado o impacto inicial, nós vamos ter que pensar as coisas.
You need
Tá?
to think about things.
Porque, bem, daqui a pouco você faz com
Soon you will
melhores
have,
intenções, tentando
we'll be
proteger o
doing things with
doente,
the best
e
of
você pode estar
intentions,
prejudicando o doente. Nós vamos ter que cotejar a
and we're
relação
damaging the person.
custo-benefício.
So you need to think about it in a
O risco de
risk-benefit
aspiração,
relation.
se ele
Risk
existe,
of aspiration
mas ele pode ter
is
aumentado
small, but it
20%,
may have
30%. Nós vamos ter que definir.
increased.
E é muito difícil que tenhamos um ensaio clínico randomizado que
Very difficult for it to
consiga
be a
dar essa
randomized
resposta.
clinical trial that's they would
Estava
give us a
tentando achar,
response.
porque você começa a ler, de repente perde o artigo.
So
Teria que dizer
maybe you lose the
240
article, you
mil
have to be
pacientes em cada um dos
240,000
braços desse
patients
estudo para a gente ter a resposta. É um ensaio clínico
to have the
difícil
answer.
de fazer, quase impossível. Bom,
It's
nós vamos
almost
ter que estar
impossible.
atento
So we will have to
e acompanhar.
pick,
Mas
pick a
existem
great database on
planos
the company. On the other hand, my anguish is anguishing because Dr. Luciana led the study that we participated on, a cohort made in Brazil with 101,000 patients. There are a group of patients that is what they call the phenotype 2 that has a mortality above 10%. The big mark of mortality is the resistance to insulin, but if there is a response to the inflammatory response, we having the metaphor transforming phenotype 2 phenotype 1 will be ideal. GLP-1 are the ones closest to this. We will have to study, we will need to redo this, the recommendation. Seeing as what happened, we have those GLP-1 is suspended. I had the inflammatory response. You'll leave this. You go to the SBA when the recommendation came out. You let the patient once again inflamed, and it's difficult for things to work out. Maybe you can strategize the others that we need to study because semaglutide, it has a oral formulations and a short shelf life. So maybe this could be done as you do with anticoagulants and a situation. Eventually, have a better look at the gastric content. If increased gastric content does not meet us, aspiration, we'll need to understand better the mechanics, from the point of view of liquids and the digestive point of view, the stomach. And these are things that we have little knowledge of anesthesia. So I just wanted to share.
Para ti, Mariana.
Great Western. Just let you know that the editorial link, Mendes Lorena,
se eventualmente alguns dos membros da audiência quiser acessar,
audience members, there's a link in the chat to download the article.
Perfeito, André.
Great, Andre.
Antes de para a pergunta do chat, eu queria
For the chat question, I wanted to get the hook on this response from the professor. We'll really have randomized studies, and we will have able to follow cohorts and take databases. And among these less observational studies, how do you identify, how would you describe the studies that will help us to improve more quickly these quick recommendations? And Lorena already described spoiler, talking about populations, about waiting times, different waiting times. I wanted you to speak a little bit more about studies that would help us to improve the recommendations in the next few months in the short term. The studies that I presented here from magazines that made for anesthesia, we don't have these studies here because there are reports of cases of respiration and happened. They go there and report it. Some people think that ultrasound, using an ultrasound test would help resolve things. We need to make these studies. The anguish that we feel with Lorena and Maristela and the editorial was that we want to have to go work in these studies. GLP-1 before heart surgery reduce the inflammatory response. Maybe we could use this in a different manner. Outside this, and some other synergy. If it was just a full stomach and there were no impact, you suspend it and that's it. Maybe there's some data, quite incipient data, that is changing the patient diet different from solid. If patients would need a solid diet, like it happens, the preparation of endoscopy, low endoscopy. So it's possible, sure. And like I've been for 9 years reducing my fasting, and the NPO at the midnight ends up having about 16 hours in the average time at the hospital, 14 hours at Santo Antonio Children's Hospital. A few patients with 23 hours of fasting and years trying to have a routine of fasting. So it's not easy to let go of that. It's so when we manage to do so with GLP-1 and then things sort of stop working, and we go back to the dogma, which is more than spread out the anesthesians. So it's something that is very, very strong. It's tough going to reduce fasting time. Now, we actually almost don't have time, but I want to make the question about the ultrasound that was actually described for you. But what I would ask, that's that the ultrasound assessment would not be a way out. Would that not be a way out? In fact, it's described in the editorial. It's a very useful tool for support, but maybe in practice, what is observed is that people don't know in which situation it will be useful, in fact. So I would ask, especially in situations where the probability, pretest likelihood is high, what would be the function of the ultrasound in these cases?
Muito boa, muito boa essa pergunta.
Good question. The editorial puts it like this: if the patient is asymptomatic, you need to treat them differently. It was a guideline. The DDT4 inhibitor would have no problems. GLP-1 increases as well. It's kind of dubious information. I understood it as an alert a year ago. Now, for me, it's no longer useful. But what happens with the ultrasound is a liquid, it's clusters. So you understand that it's dynamic axis. So it's another discussion. Discussion is another context. The ultrasound gave me the other two things. When I intubate the patient, you put them on their side. Why do you use ultrasound on their side? Because we're doing all the content for ATRA. I'm using the gravity strength opposite regurgitation. So we call this but the propulsion of the content is always on these out of the esophagus to the intestine. I need to use that in my favor, in the favor of the patient. So ultrasound, yes, if I get solid content, it's different because aspiration of liquid and solid content is, well, it's not the same thing from the physiopathology point of view and the risk for the patient. And it's a syndrome that is slightly scary because it's an illness with a high mortality. Intubation, it's an extubation. We need to think about this context as well, because those are the important ones that comes from the Mariana that patients need to have their neuromuscular blockage very well averted, well affected.
Então, é dividir angústias? É provocar publicações? Sim.
For publications, sure.
Entender que o GLP-1 é relevante, como eu acho que ele é, e eu acho que a gente vai usar GLP-1, eu já estou pensando em eu usar.
I'm thinking about, it's so protective.
Puxa vida, pena que não tem tempo.
Just, it doesn't have time. It diminishes the fibrosis in the heart, improves the lung surfactant, and is the anti-inflammatory by excellence. That is insulin. No, it's the arm of this anti-inflammatory. Is GLP-1. The discussions for us to have, because there are a few, the hematoencephalic barrier. These are different actions. The GLP-1 is what we're talking about. It improves the function and improves the patient, that diminishes the neuroinflammation, and we need to pay attention. We don't have anesthesians that do this, without doubt.
Excelente.
Great.
E eu acho que depois
And
dessa
I think that
apresentação,
after this presentation, we all
bem convencidos
are
e
well convinced
entusiasmados.
and enthusiastic.
Com certeza isso deve ser
And for
levado
sure,
em
this
consideração
should be
para que
kept in mind,
e reformulemos as
and we
recomendações.
will formulate the recommendations. And Mariana as well. I think it will be worth it at this point. They'll have a narrative revision about this subject.
Nós tivemos olhando se vale revisões sistemáticas e olhamos, tá meio complicado. Tem algumas, tá?
And there are a few subjects that are already here, but we need to pay a lot of attention thinking about magazines. And there's a lot of publications. This is, in fact, a very serious discussed subject. We're still not using this in the public health system, but this will happen soon. Every N5, and there are other types of associations associated to insulin, for slow release insulin associated to inhibitors of the two discussions, and the receptor agonist, GLP-1 agonist in the GIP. It's a very clearness, very good. And the cardiologists are enthusiastic. At least ours. All right. That's very interesting.
Muito bom, professor.
All right, Professor. Sadly, we are at the end. So, our webinar, Brazilian Journal of Anesthesiology. And we thank you for your participation. So, see you soon. Thank you very much to all of you. Thank you, everyone.
Muito obrigado, parabéns. Ótima noite a todos.
Boa noite.